This episode talks about mental health challenges like depression, anxiety, schizophrenia, suicidal ideation, and navigating grief. Please listen with care. If you need support, we've got resources listed in our show notes.
The first time I saw it, I was kind of in awe. It looked completely unlike anything I'd ever seen in mental health services before.
This is In Our Heads, a TVO Today podcast about generation distress. I'm Tiffany Lam. Chaz Langford has been involved with his hometown's Access Open Mind since he was 14 years old. Chaz is from Chatham.
My legal name's Charles. I go by he, him pronouns, and I've been involved in a number of different sort of mental health roles, the first being with Access Open Minds.
Access is actually an acronym. It stands for, and this is a mouthful, Adolescent/Young Adult Connections to Community-Driven, Early, Strengths-Based, Stigma-Free Services. A worthwhile vision.
And honestly, it kind of looks like a startup if you kind of get a picture in your mind.
Am I in Google?
Yeah, I know, exactly.
At Chatham's Access location today, you can get different kinds of mental health support all in one place. A therapist, a first responder, or a caseworker or peer navigator who can help point you towards a resource that might make you feel better. Maybe more like yourself.
The front area, it's a big open space. There are windows in the front, however, they're kind of glazed over, so obviously you can have some level of privacy, but it's a very bright initial room. There are essentially various rooms with different themes. And there's a beach theme and all that kind of stuff. It's kind of neat. It's fun. It makes things sort of laid back. And the sites, they can look different from wherever the community is. As much as it is a Canada-wide project, it is up to the individual sites to sort of see how specifically it looks like. And Access was it was a pilot project, I guess is the proper term. And it was designed to see, can this work?
For those who've never been to Chatham before, it's in southwestern Ontario with a population of 105,000 people. My friend Sophie, who's got family in Chatham, tells me it's a very flat place with some of the best farmland in the province for soybeans and corn used to make ethanol. People love going to flapjacks for breakfast, and for a special edition of Monopoly Canada in 2010, the makers of the board game chose Chatham Kent to be its boardwalk spot. A popular vote mobilized the region, which their family found hilarious. Chatham helped lead the way in reimagining mental health care for youth in Ontario and across the country. What got you working for them?
I think it was my grandfather, he's kind of involved with this city and all kinds of different projects and stuff. And I think he had seen that there was a ad in the newspaper seeking for youth involvement in a new project, a new youth mental health project. I think it was through Rotary or something.
The ad was calling for youth consultation on a project that didn't have a name yet.
So I thought I would join because I had already known that I'd been experiencing mental health issues for quite a bit.
The initiative in Chatham was part of a national pilot project. It received $25 million in funding from the Canadian Institute of Health Research and the Graham Beck Foundation in the early 2010s.
We just knew that it was going to be this sort of hub for youth mental health services. When we were conceiving that, we were focusing on what does it feel like? What does it look like? What do we want this site to be like? In terms of a lot of it was very qualitative in that it was we wanted it to be a sort of a connection to the clinical environment, but not the initial clinical environment. And that is essentially designed to smoothen the process between youth and connecting with mental health services. So it's designed to make that whole process a lot less confusing. And it's ultimately any sort of thing that's involved with mental health, youth mental health specifically, is connected there.
Access doesn't only offer more traditional resources like social workers and therapists, it also acknowledges that youth finding their community, a sense of belonging, plays a big part in mental health.
Because especially in small towns, it exists everywhere, but especially in small towns, that connection with other queer youth is really, really difficult to find.
Chaz found solace in Access hosting events for organizations like Young and Proud.
Being a gay youth in Chatham, Ontario was really taxing because I was in a very, quite frankly, a conservative community, and it was really, really hard because you couldn't tell anyone. And you probably could, but you'd be risking a lot. You'd be risking friends and all sorts of things.
Isolation, as we've learned in this once-in-a-lifetime pandemic, is another reason why many people struggle with their mental health. Studies show that feelings of intense loneliness can actually generate cortisol, the stress hormone, and that can impact brain function, compromise your immune system, and increase heart diseases. It also increases risk of depression and anxiety. Now, I don't know about you, but I'll admit I felt a certain wave of relief when I was able to see more friends again and go to a party again. And I think Instagram captions call that feeling your heart being full.
I think we've just been approaching the mental health system wrong because we've had this separation with the community sort of aspect, and it's really counterproductive because mental health is a myriad of factors that contribute to youth feeling really poorly.
Psychiatrists we spoke to, like Dr. Amy Gajaria, say the field of medicine grapples with what role doctors play if health, especially the mental variety, is in fact made up of said myriad factors. The fancy academic word for it? Social determinants of health.
So social determinants of health thinks about things outside of your illness that affect your well-being. Things like housing security, access to food, access to employment, absence of experiencing oppression or racism, or sexism or transphobia. Immigration status is also one of them.
Dr. Kajaria thinks physicians and mental health care providers advocating for improving these determinants of health is important. It's part of the picture of health. But others draw a firmer line.
Sometimes doctors say it's not their job because it's not like a medication or a pill.
Dr. Kajaria is a youth psychiatrist at CAMH, the Center for Addictions and Mental Health.
If somebody is homeless, they can't eat, they can't afford to pay their bills, you can do all the therapy you want, but it's very hard for them to start to feel better.
The fact that Access offers that integrated space feels like it's honoring this holistic picture of health. But it also has the added benefit of addressing different problems mental health providers have named. For instance, Access offers its services to people aged 11 to 25.
And so getting it up to 25 does allow us to capture folks as their brains are developing, to continue to involve families, which for most young people are still really important at that age, and help them kind of launch out into adulthood. And if pediatric services end at 18, then someone has to, in the middle of their illness, figure out how to transition to a whole different system that's not youth-focused.
Access also helps with navigating the different services that are available.
The most common thing I hear from families is, I have no idea how to navigate this system, and it is such a source of frustration. So being really clear with people, if you have this difficulty or this problem, what's the first step in through the door? And can we take on the responsibility as a system of helping people know how to navigate?
Access does just that. It takes responsibility for triaging people based on their needs. And Access's goal from the jump was to help people name and address problems they're facing early. It still is. Early identification and intervention for mental illness has proven to pay dividends already. Preliminary research from Access showed that for every dollar invested in its services, $10 in service costs is avoided later down the line. Here's Chaz again.
That includes people calling 911 when they're having a suicide crisis, for example, or that sort of emergency care. That is very, very expensive, and it's very preventable. If someone is in the emergency room where they call an ambulance, that's a lot of money spent where we could have helped them way further before, and it would have prevented that altogether.
Access's sites have decreased hospitalizations and emergency room visits by connecting people to the appropriate services. It's streamlined getting people where they need to go instead of clogging up emergency rooms.
This sort of system, it shortens wait times. I think it's like 48 hours is the goal with youth connected in initially. And then I think within 30 days or something like that with an actual service that they're connected with. They found that I think it was something like 90% or close to 90% of youth would recommend this service to another friend. Over time, to be 100% honest, this involvement has probably been the most meaningful thing I've done in my life in terms of leaving an impact on the world. And I'm very, very proud of what we've done and what we've accomplished so far. It's flying colors. It's worked really, really well.
Access's model has been so successful that the Ontario government has started to adopt its approach, repackaging it as Youth Wellness Hubs Ontario.
Youth Wellness Hubs Ontario was a few years after Access was initially created. So Youth Wellness Hubs Ontario, I don't think it was entirely based, but I think it was quite inspired by it. The sort of hub model that was sort of I think what inspired them.
To rewind and offer some historical context, in March 2020, the Government of Ontario unveiled the Roadmap to Wellness, a $3.8 billion plan to inject more money into addressing the mental health care crisis. $380 million a year, in theory. The announcement details how its funding will be spent over a decade between 4 pillars. 1, improving the quality of existing services. 2, expanding existing services in, quote, priority areas. 3, implementing innovative solutions. And 4, improving access. Part of the Ford government's plan to implement solutions meant evaluating hub models, places that offer mental health care through, and I cringe a little at this saying because I feel like it's a bit of a corporate catchphrase now, a one-stop shop. Cringy catchphrases aside, the minister leading the charge struck me as eager to speak on the issue when I thanked him for making time for us.
I love to talk about it because I think by talking about it, we deal with the stigma associated with it, and we don't want people not talking about their mental health. So my name is Michael Tobolo. I'm the Minister responsible for mental health and addictions for the province of Ontario, former lawyer, and ran a residential therapeutic community for men with addictions. That started me into a career of studying mental health and addictions, and I'm doing my doctorate in clinical psychology right now.
The announcement in 2020 detailed how this province was evaluating 10 different sites for youth wellness hubs. And today, Chatham-Kent's Access location has the same address as Chatham-Kent's Youth Wellness Hub Ontario.
We've created youth wellness hubs to give people a safe space to allow them to go and get the support they need and not feel that they were somehow inferior or had a problem, that it was normal.
Premier Doug Ford created the position of the Associate Minister of Mental Health and Addictions in 2019, a file that falls under the Ministry of Health.
And I was given the opportunity to develop the plan. And of course, doing my doctorate while I'm the minister gave me the opportunity to use all the skill sets that I learned through my courses.
The first thing that was important to Minister Tobolo was to have Ontario recognize that people at different stages of their lives need different kinds of support. Youth needs and life experiences are very, very different from a senior's.
The second part that was really important to me was building a step care model so that we had a kind of hub and spoke model that gave us the opportunity to provide supports that were commensurate with the level of the need for the individual.
Imagine a bicycle wheel. The hub and spoke model that the minister is referring to is essentially a distribution network. Imagine all that demand for services being triaged from the center axle to different places in the outer rim or tire as needed. And stepped care is a model of care that recognizes people require different types of medical attention at different stages of their mental health struggles. Early steps include online resources, group therapy, peer support, and maybe a single session with a therapist. And later steps include continuous one-on-one sessions, specialized psychiatric, medicated help, and hospitalization. Those steps should be navigated with ease, potentially with support, and aligned with the person's mental health needs. One model thinks there should also be room to allow the individual to pick the steps that they feel ready for.
Everybody suffers from anxiety and depression. Most of us shake it off and we are able to function. Some of us have a mild form of it and it's a little bit more limiting in terms of being able to work. Some of us have acute, and so building a model that basically addresses the needs for those different people.
For Minister Tobolo, the only person to ever fill this associate minister position, youth wellness hubs facilitate early access to mental health services at this critical, transitional time. I see the logic in adopting Access's model, particularly when it's already proven to be successful.
So our government, based on what we're seeing, not on what we think, but based on hard evidence, we're establishing a network of supports that are based and really geared to the age that we're trying to look after.
The government's estimates showed that it had spent $241 million more on community mental health than what it had budgeted for, almost a 23% increase. That's from a 2021 report from Ontario's Financial Accountability Office. But despite this cash flow from the Roadmap to Wellness, a youth wellness hub in Windsor, Essex is reportedly not getting all the support they need.
I was at an announcement through CMHA here locally who were announcing their youth wellness hub, and they're moving into their new home.
CMHA is the Canadian Mental Health Association.
I'm Lisa Gretzky, she, her. I'm the MPP for Windsor West and the NDP critic for mental health and addictions.
I have a pretty good impression of Windsor. My colleague Kat Eschner reported on the city last December for the series Recession Road. I'll paraphrase from her piece here. Despite a long-standing cultural perception, Windsor doesn't suck. It's got a cosmopolitan air surprising in a municipality of fewer than 230,000 people. It's home to the busiest land border in North America in terms of trade volume. And it's surrounded by some of Southern Ontario's most strategically important farmland. When I've crossed paths with Windsorites, they've seemed like down-to-earth, hardworking folks. MPP Lisa Gretzky also sees it in her work on getting youth wellness hubs up and running in her riding too.
What I saw today, a shining example, is that these community agencies are coming together and working together, but they're having to fundraise in order to actually be able to provide the supports and services that people need.
When my co-producer Matthew got in touch with the youth wellness hubs in Windsor, Essex, a representative told him that fundraising largely went towards a new facility in downtown Windsor. Funding from the government only covers staffing mostly. Kim Willis, the director of communications at Windsor's Canadian Mental Health Association, told Matthew that government funding is not keeping pace with the need. In fact, MPP Gretzky says that while the Roadmap to Wellness is a large investment in mental health, there have been cuts to specific parts of the services. The Financial Accountability Office corroborated this in their 2021 report on health spending. There was a $71 million decrease in child and youth mental health services, a 14% decrease.
And essentially what they're doing is they're taking away the people who actually provide that support. And so there's an uptick in not only the number of people requiring supports and services, but the severity and the wait time in order for people to be able to access those supports and services. So as they're cutting funding, more people are in need of the service, and those needs are getting greater and people are waiting longer. And the longer they wait, the greater their needs are going to get.
Sums of money in the millions is very abstract to me. Like, what does $241 million more do for community health? What does it mean that there's been a $71 million decrease in specifically youth-centered services?
It means that there's fewer experts in the field to be able to provide the supports. It means many of our community agencies are closing because financially they can't stay afloat. It's not because they don't want to provide supports. They want to. It means more financial impact on the community as they're out. These agencies are out fundraising to try and stay afloat to be able to offer services.
Time and time again, I've heard that youth are not just smaller adults when it comes to medical needs. There's specialization there. MPP Gretzky also named another problem. Services are not talking to each other enough.
I think that it's really important that when someone is trying to access support for mental health or addiction, that they're not having to repeat their story over and over and over again. The system needs to be much better connected to avoid that from happening, because the more somebody has to repeat their story, the more likely they are not to stay engaged in the system at all.
Not to mention, it's kind of re-traumatizing.
It absolutely is re-traumatizing. So that's a very, very important piece, and that should be something that's implemented across the province through all service agencies, is recognizing that sometimes having to tell the story over and over again compounds the problem, having to relive that trauma. I point to the fact that the government is saying all the right things, but they're cutting funding for those supports and services. You look at the bigger picture, if you look at what they are or are not spending in mental health and addictions, they're not treating it as though it is part of healthcare.
Minister Topolo, I think, took some offense to that sentiment when I mentioned that criticism.
Someone who criticizes and says that we don't treat mental health like health and that there's a disconnect there is completely and totally wrong. There are 16 ministries that I work with each and every day, and we coordinate our work to ensure that we are looking after the person in a holistic way, in a continuum of care, to ensure that the person is getting appropriate services where and when they need them. Unfortunately, I've only been in this position 3 years now. You can't change a system in 3 years, but you can lay the foundation. And after 15 years of neglect under previous governments, we're going to fix this problem, and it's my intention to stay here till I get it done.
I can hear Minister Topolo's determination here. And I'm sure they're aware implementing this model doesn't mean that the job's all done. Here's Chaz Langford, one of the consulting youth for Chatham's Youth Wellness Hub again.
One of the flaws of Access's model is largely that it's part of the larger system, in the sense that these services it referred to also require increased funding, because as much as it can connect people and it can hire some staff, the mental health system as a whole, I think, needs funding in general as well, because that is kind of a systemic thing.
Remember the hub and spoke model that Minister Topolo was talking about earlier? Just to ride out this bicycle wheel metaphor for a moment, as key as it is to have a working axle, a flat tire does the rider no good either. But maybe pumping the tire is insufficient because the tire itself is leaky. Maybe we need to seal it up somehow, or maybe we need a new tire or a new frame. And to find out which, the bike needs to be serviced, and to make the appropriate repairs so we don't get charged for a part we don't need, it's crucial for the safety of the rider to understand what constitutes a proper working bike.
A system is one in which you understand what's happening. That kind of information needs to be collected routinely, and with few exceptions is not in the mental health and addiction system in Ontario.
That's Dr. Paul Kurdiak. He's a psychiatrist at CAMH, Vice President Clinical of the Mental Health and Addiction Centre of Excellence at Ontario Health, and the lead of the Mental Health and Addictions Research Program at the Institute for Clinical Evaluative Sciences, ICES. In short, he thinks deeply about mental health care in Ontario. Coincidentally, he also happened to bike to his interview to see us. You seem totally fine and not, exhausted.
Oh, I came 2 hours earlier to cool down.
So Dr. Kurdiak just mentioned that more information needs to be gathered by the system. But it's important to note that the data that is being gathered isn't really all that promising.
When somebody is hospitalized with a diagnosis of schizophrenia, there's an expectation that when that individual is discharged or leaves hospital, that there will be continuous care in the form of follow-up, particularly with a physician, whether it be a primary care physician or a psychiatrist. And there's a quality standard that should happen within 7 days of leaving the hospital. Only 1 in 4 individuals are seen by a physician within that quality standard. And then another stark example, we looked at individuals who came to Ontario emergency departments for a suicide attempt, and saw the proportion of those individuals who saw a psychiatrist within 6 months. Now, a suicide attempt would be are heart attack. This is a crisis. This is where you want really rapid response to save lives. And only 2 out of 5 individuals saw a psychiatrist within 6 months of that attempt. We're only treating half the individuals with depression. We know that we're only treating half the individuals with the first diagnosis of schizophrenia. The system as it currently exists is strapped and overwhelmed, but we also know it's not meeting population need.
For Dr. Kurdiak, there's 2 parts of a working system of healthcare. The first is a uniform level of care across the province that meets medical standards.
It shouldn't be different if you're in Sudbury or James Bay community or Toronto.
The second is metrics and data that help us understand what we're doing so that we know how the system is functioning.
I would say that in my ICES role, where we use system data to try to describe what's happening within the system, one of the overarching conclusions of 10 plus years of work with these data is that we do not have a system. There is no mental health system.
Certainly, Dr. Kurdiak has access to data his organization has collected about the state of mental health care. But which ears this data is falling on is unclear. MPP Gretzky, the NDP critic on the mental health and addictions file, says that there's actually a lack of data to inform her work.
Without that information, it's very difficult for anybody to truly hold the government accountable.
And Dr. Kurdiak was especially unimpressed, given that the COVID-19 pandemic has shown that the government does have that capacity to gather data to inform policy choices.
In March 2020, within weeks, the provincial government, the Ministry of Health and public health agencies all did this massive and very legitimate investment in resources so that within days, we knew how many cases there were daily, we knew how many hospitalizations were daily, we knew how many ICU admissions there were daily, and how many deaths. And then the question is, what investments have we made to understand what mental health needs are? And in the absence of such information, how on earth can you plan?
And to be fair, though, Minister Tobolo did say that his government's choices weren't arbitrarily made, but he offered very little specifics of what data the government is currently using.
We are making investments that are tied to performance. In other words, the metrics that we generate from there, if they are giving us the results that we want to see, then those are investments that will continue.
And one last thing I think is worth noting. What good performance may mean can be different depending on your vantage point, whether you're in the government or a community organization. Here's MPP Gretzky, the NDP critic again.
We need to be leery of government having complete control, because then you run the risk of the fact that they're not listening to the community agencies who know where the gaps are in their communities and how to fill those. When you're having the government completely make all the decisions, right down to how every single dollar is going to be spent by these agencies, you run the risk of a disconnected government making the wrong decisions, thinking they know best, instead of letting the communities have flexibility and filling in those gaps as needed.
Dr. Kurdiak suggests that our mental health care system needs to emulate something that Ontario does well, cancer care.
The way we fund mental health and addiction services is very different from the way we fund cancer care, where there's data on how many volumes are expected based on what they measured last year, for example, and there's data on the quality of care. And so everybody gets a certain funding for volume, and then there's a quality-based funding that incentivizes good care. What happens in mental health and addictions is there's just a funding for services.
And when it comes to cancer care, it is certainly true that there is a level of hand-holding that appears absent with mental health care.
If somebody's treated with a course of cancer, their outcome is being monitored. And if they don't respond to the first line of treatment, they are navigated into second line, third line, etc.
Escalating.
Exactly.
Yeah. I'm deeply familiar with this escalation of care. My dad was diagnosed with pancreatic cancer in 2022. My dad, for example, had gone to his family doctor with complaints of aches and pains in his back and abdomen. Seemed typical for a man in his 60s until he started complaining about persistent fatigue and the doctor started noticing weight loss. These new symptoms got him a referral to do some scans, and when the primary care doctor saw those scans, he referred him to a surgical oncologist who then determined cutting the tumors out wasn't really an option. The surgical oncologist referred my dad to a medical oncologist at his closest major treatment center for assessing whether he could even do chemo.
Cancer care doesn't occur just anywhere. They've figured out where they should put regional cancer centers who provide excellent care and then make sure that access is equitable across the province. So then the question is, how do we define and capture the clinical population? How do we figure out ways to get that population into care systematically?
In Dad's cancer case, the medical oncologist took one look at him, asked him some questions, and immediately flagged the need for an occupational therapist to assess my dad's apartment to make sure that he had what he needed to be able to do the day-to-day things as he deteriorated. That same oncologist eventually connected me with a palliative care doctor and nurse, and then she recommended hospices to start researching and eventually connected me with a social worker too. I tell this story of the futile attempt to delay my dad's death in April 2022, really only to highlight that at no point did I have to lift a finger to figure out where to go between all those different healthcare providers. Sometimes I wonder, if he was referred to where he needed to be directly enough, fast enough, but I'd like to believe that his referrals and follow-ups being all within about a week of each other at that time was because of this sudden collective recognition that his illness was now serious. I was contacted regularly, given very specific instructions from a doctor, a nurse, admin staff, maybe an automated email on occasion, saying go to this physical or virtual place at X time, or get his blood work done as soon as you can, or here are your options now. And according to people we've interviewed, both experts and youth with lived experiences, that is not how mental health care works. And it's unfortunate because even though comparing mental health care and cancer care is, likely not the same, I'd imagine mental illness can be debilitating for the person and their caregivers in the same way.
We are benefiting from the expertise of our Cancer Care Ontario colleagues, the data and digital teams that are supporting them. We're now living in an age of electronic health records. Mm-hmm. So I think a lot of this expertise, provincial expertise, while it doesn't necessarily exist in the mental health and addiction sector for obvious reasons, it does exist.
Between 2001 and 2005, Ontario built an infrastructure for cancer care. They defined standards of care, created metrics to measure success, and implemented a system for public reporting and ways to improve. This capacity planning informed provincial investments. And as a result, the government says wait times have decreased, quality of care has improved, and more people are surviving and living with cancer.
I think, building a mental health and addictions system that serves all individuals with such issues is going to take years and years. But I do believe that we will show early evidence of the kind of systematic delivery in certain areas, which I think will be incredibly important for the rest of the sector to see and to learn from and to get inspired by. There's never been a better time to do some good.
What's the future for Access Open Minds look like?
Yeah, I would like to see, honestly, sites in every community, every major community, and hopefully serving all these smaller communities. What I would like to see is this project be adopted at a full national-wide level.
Potential opportunities to imagine that you're at a beach across the country sounds pretty nice, honestly. But Chaz doesn't want Access to have to rely on funding from its original donors at the Graham Beck Foundation or other research organizations anymore.
It was never necessarily supposed to be funded in that way the whole way through. It was just to prove if that model can work, and it did prove that.
The blue sky goal that Chaz has is for Canadians to be able to see a mental health professional the way they see a family doctor, free of charge.
The more ambitious goal is we need to improve the funding for Canada-wide, like therapy, for example, like just general psychotherapy, even if you don't have a sort of defined mental illness. If you are saying, I need help, but there's a financial constraint to me getting help, that is a huge, huge problem. So, I mean, that's another whole different kind of tangent, but that's the greater goal. But the initial goal is I want to see all across Canada. I want to see these sites pop up.
Next time, we'll tell the story of one family who has questions about when youth should be prescribed antidepressants.
I don't see how the benefits would outweigh the risk.
We'll put that story in context of psychiatric medication for Canadian youth today.
Psychotherapy is not as available as antidepressants by a long shot.
The thing I worry about is, are we just using medications as a simple, cheap, and quick Band-Aid for something that requires not just medications?
Thanks for listening. We tried to make this episode more solutions-focused, but if you're feeling like you need help, know that you can always call Wellness Together Canada at 1-866-585-0445. You can also text wellness at 686868 for youth or 741-741 for adults. We'll also list more resources in our show notes. In Our Heads is hosted and written by me, Tiff Lam, and co-produced with Matthew O'Mara. Matthew and I also did some additional reporting and edit the show. This show also relies on reporting from Generation Distress, an investigative journalism bureau series published in the Toronto Star. The team was led by Robert Cribb, Declan Keogh, Julia Fioni, and Charlie Buckley. This episode got production support from John Michael McGrath, Nikki Ashworth, and Jonathan Hallowell. Shahriar Tajvidi is managing editor of podcasts and digital video. Lori Few is executive producer digital. And John Ferry is VP of Programming and Content at TVO. Thanks again for listening.